Our next presentation is going to be on the Miller-McEntire Periodontal Prognostic Index, which, as you know, is on my web textbook as well. This is divided into two parts. The first part is the background and development of the concept, which will be this particular video, and a second video will be on the clinical application. The index is used to determine the long-term prognosis on periodontally involved molars, but it can be applied to single rooted teeth as well. What do you say when a patient asks, if I have this periodontal treatment done, how long can I expect to keep my teeth? Currently the answer is, well, it all depends. It depends on this, it depends on that. But now we have the answer, the MMPPI, or the Miller-McEntire Periodontal Prognostic Index. This is evidence-based research. It is statistically validated. It is accurate. It's been published in the Journal of Periodontology, and it was a Clinical Research Award winner in 2015. How was this index derived? First of all, using data collected from a complete periodontal examination and patient's history in my private practice was used as the determining factor. Data was collected on 816 molars on 102 patients. The inclusion criteria for statistical analysis was very tight. All patients had to have a diagnosis of moderate to severe chronic periodontitis. This was obvious because my practice was a referral practice and we did not receive patients with gingivitis or a slight periodontitis. But here's the criteria that eliminated most patients. Patients had to have all 8 of their first and second molars present at the initial exam. And in the original article, the average patient coming into the practice was 42 years old. And a 42-year-old patient with moderate to severe chronic periodontitis, 90% of these had already lost 1 molar. So 90% of the patients that we treated were necessarily eliminated from our statistical analysis. And all patients were a minimum of 15 years post-treatment, and we'll talk about the significance of that now. The patients were a minimum of 15 years post-treatment. The average patient, when the study ended, had been in the practice or in maintenance for 24.2 years, and this ranged anywhere from 15 to 40 years. The 7 factors that make up the index are as follows: age, diabetes, smoking, molar type, probing depth, number of furcation involved, and mobility. Now you will notice here that patients under 39 scored a 0, and we will discuss that in depth in a moment. But the one I would like for you to focus on was diabetes, because we did not have a statistically validated score for that. All the rest we did have a score on. Now, I know what you're thinking. What about plaque? You didn't score plaque. How accurate can a prognosis study be that doesn't score plaque? Well, first of all, you got to remember that this was done in a private practice. It's a retrospective study, and had no idea that we were going to publish this work. But if you think about it, how do you score plaque? Do you do a PI index, a GI index? And how many people do that in practice? Virtually none. And also, plaque scores varied so much over the period of time, often based on psychological problems with the patient, such as a child getting killed in an accident, and all of a sudden the plaque would go down, or something positive would happen, the plaque scores would go up. But you will note in the keys to success, brushing and flossing and cleaning your tongue are one of the first things we have as a key for success. Diabetes mellitus as a prognostic factor. Interestingly enough, only 2 of the 102 patients included in the case study had a diagnosis of diabetes mellitus. Therefore, there were an inadequate number of patients to validate statistically. Therefore, we use a hemoglobin A1C levels as a basis for including this as a factor, using this textbook as a basis for determining the A1C levels. Currently, a prospective study for determining an evidence-based, statistically validated quantitative score for diabetes mellitus in molars has been submitted for publication, and that will determine if our conclusions about the A1C score levels are accurate or not. Scores for diabetes. If the A1C score is not available on the patient with diabetes mellitus, we arbitrarily assign a score until an accurate A1C score is available. An accurate A1C score can be determined using the A1C level in this home or office testing system, which only costs about $12 to $16. And the Miller-McEntire diabetes score for a 7.1 would be a 2. The impact of smoking. Patients who smoke were compared to non-smokers with the same level of periodontal disease. The risk factor for losing their teeth was 246%. So smoking was the most significant factor in determining the prognosis. How significant was smoking? 4.9% of the patients were heavy smokers, at least a pack a day. They lost 26% of the teeth extracted. So I think that some level of smoking counseling should be given to all patients for those of us who are in the healthcare professional. And one of the videos on this website is smoking cessation counseling, about a 3-minute video that I would urge you to look at to see what can be said in a very brief amount of time. An interesting finding: when extraction data were analyzed, 34.63% of the molars extracted were maxillary second molars. I think this comes as no surprise because the maxillary second molar probably has the poorest prognosis of any tooth in the mouth. And how long do teeth with furcation involvements survive with treatment? There are many studies out there that suggest that a high level of tooth retention compared with implant-supported restorations is comparable. And this is just one of those studies. We talked about class of mobility. Let's elaborate on that for a moment. Class 1 mobility means that although a tooth is mobile, the clinician does not think the degree of mobility is impacting the prognosis. A Class 2 mobility means the clinician thinks the degree of mobility is impacting the prognosis. So let's look at two scenarios. One, we have a 29-year-old patient missing his mandibular molars and is going to have a bilateral free end saddle partial made, removable partial denture. Obviously, this is going to put stress on these teeth in a young person, and I would be concerned about mobility, so I would classify the mobility on those two premolars as a Class 2. Now, I'm almost 80 years old, and I've got all my teeth, but let's say my second premolars have exactly the same amount of mobility as that 29-year-old, but obviously I'm not going to be concerned about it. So even though the mobility is the same, in my mouth, I would have that as a Class 1. Class 3, the tooth is possibly hopeless, but can be treated under certain circumstances. So here we see the summary on that, and we need to determine a statistically validated score for diabetes, and because smoking is so significant, I think a score research article on just smoking from a prospective standpoint is certainly indicated. We use a Cox proportional hazard ratio, and the lower the ratio, the less significant that factor is. So you can see that age is a 1.27 and smoking is a 3.46, which shows that smoking is much more significant a prognostic factor. And as we look at this, age is a 1.27, furcation involvement is a 1.21, molar type is a 1.20. Those are the least significant factors. Probing depth and mobility are about the same, but you can see that smoking is off the wall. Why do we use a hazard ratio rather than a relative risk ratio? We had a total extractions of 175. 32 molars were extracted during active treatment, and 143 molars were extracted during the maintenance phase of treatment. If we had used a relative risk ratio, the 175 teeth that were lost before the termination of the study would necessarily not be included, and our sample size would be much less. So a score of 4 for smoking was evaluated statistically and found to be valid. However, because this is so significant, a study has been submitted, which is a prospective study, to validate that smoking is in fact as significant a factor as we thought. So here's the score sheet we used, and we looked for the result of the Cox proportional hazard ratio. And if we draw a line at 15 years, we can see at 11, the prognosis of a tooth with a score of 11 was 53%, lasting for 15 years. And a 67 would be on a tooth with a score of a 10, which are highly significant numbers. Now, 641 molars survived, and after we've determined the scoring factor, then we can look at these. 78% of the teeth survived. But the question is, did they survive in health, which would be successful, or did they simply survive with periodontitis? So survival in health is characterized by an absence of inflammation, which may be appear clinically as redness, suppuration, and bleeding on probing. This was a position paper published by the American Academy of Periodontology in 2011. Of the 641 molars that survived, almost 90%, 87.6, met the AAP criteria for survival in health, just showing how significant an impact periodontal treatment can have in improving prognosis. If teeth are maintained for many years, in this case 24.2, some of the teeth will require retreatment. So the answer is the frequency. Some retreatment will be required every 6.7 years. The type of retreatment, 60% will require non-surgical treatment, and 40% will require additional treatment. And this is data provided by Fardall and Associates in the Journal of Periodontology in 2012. So we go back to the factors involved, and we found that age, and we found molar type, and we found furcation involvement were not particularly significant. We found that smoking was the most significant factor, with probing depth and furcation involvement in the middle. These are the keys to success. And you'll notice the first one addresses plaque control, which we discussed earlier. They've certainly got to brush and floss. And also they need to clean the tongue on a daily basis. And this will be the topic of a separate video on cleaning your tongue, which I would urge you to look at. The reason for this is after you've brushed and flossed, 90% of the bacteria remaining in the posterior part of the mouth are on the posterior third of the tongue. And these are the bacteria that cause malodor or halitosis or bad breath, so I would urge you to look at that. Second, the patients have to have the recommended treatment. They have to be on the maintenance schedule and follow the maintenance schedule that you recommend, and they need to stop smoking or at least cut back. And with diabetic patients, they are highly encouraged to control their blood sugar. So let's look at the conclusions. Young people with moderate to severe disease can have an excellent prognosis if their disease is treated aggressively. You got a 25-year-old with 7 and 8 millimeter pockets. We perceive that this patient has a poor prognosis. So rather than waste their money on surgery, we simply do non-surgical treatment. But we know full well in pockets of that depth, we're not getting the calculus off. The disease process will continue and the patient will lose their teeth. So go ahead and flap these areas, clean out the calculus, and the patient can follow the keys to success and have an excellent prognosis. Smoking. As we have pointed out so many times, this is the most significant factor, and the prospective study that has been submitted for publication will validate that score. And finally, furcation involvement is not nearly as significant a factor in determining prognosis. But unfortunately, too many dentists look at x-rays, see a furcation involvement, and figure that tooth is a hopeless tooth, and often it is immediately extracted. But the data here clearly points out that this is not the case. So let's go to a video by Dr. Robert Levine, who will discuss his experience in using the MMPPI.
Okay. Yeah, hi, my name is Dr. Robert Levine. I'm a periodontist in Philadelphia. And what I could tell you from a standpoint of what the MMPPI means to me and our practice in Philadelphia is that it finally gives us the opportunity to tell a patient the prognosis of their whole mouth from a standpoint of just measuring one tooth. And how do we do that? I have a patient coming in today named Mitchell, who we're doing a full arch of laser therapy in all 4 posterior quadrants. In his mouth, we scored tooth number 3, which was probing 7s generally around the whole tooth with a class 2 furcation. There was no mobility. He's in his early 60s. So when we got the total, it was a total of 7 on the index, and which means an 86% prognosis and a 30-year prognosis of 66. So this is the first time in my practice that I could actually tell a patient with some confidence that we have the ability now to tell them what the prognosis of their mouths are from a standpoint of keeping their teeth, as long as they go through the treatment and the criteria for success, which is on every sheet. I review this with the patient knee to knee, eye to eye, go through each number and why. So there's 7 categories that we look at and come up with the total. And it gives us the scores, as we know, 15 and 30 years. But we really make it important and review the criteria for success. He is a smoker, and he smokes about a half a pack a day. And by just eliminating smoking, as we know, the smoking increases the risk to about 250%. We could get the numbers down to a 5 or even a 4, and then he has no chance, based on the 15 to 40 year research in PD study, he has no chance of losing teeth from a statistical standpoint. So this is very powerful. The value of this is now I'm able to share this with our patients. The patients have a really good understanding. It motivates them tremendously to go through treatment and motivates them also to reduce or quit smoking. We give a copy of this. I call this the Perio report card. So they get this. We've always been graded on a report card scale since we've been young. And this is another way that we could grade our patients, and they get value of this because now they could watch things improve in 6 months or a year. So PD, from the bottom of my heart, thank you so much for all your hard work in periodontics. We've been using your class 1 through class 4 categories for gingival recession, but to me this is the most powerful thing that I'm able to share with my patients. And it's in my heart, I'm a periodontist first, a dental implant surgeon second. So thank you for saving more teeth, and PD, I love you. You take care.